My name is Dr. Hattie. I am a GP in a practice in London, and when I'm not in practice, I spend time with NHS England as the clinical lead for AI and digital workforce, and for one of our health innovation networks in England as medical director in the southeast of England. What we're going to be doing today is posing this question with some experts in the room that work across international governance, with backgrounds in law, backgrounds in working in industry, and experts in policy. And I want to pose why we're going to be considering this question. But before, a little bit of housekeeping. We are recording the webinar today. If there are any issues with this, please do let us know, because we will be sharing the webinar. But in terms of who's on camera, it's very much the speakers on the spotlight. There is an opportunity to interact, and the second half of this seminar today will be taking questions and providing answers to our panel. And we're happy for you to pose questions, particularly in the Q&A box as part of the Zoom tool. And we're also happy to follow discussion in the chat, and we've got a wonderful team working here behind the scenes to pick up some of those nuances and questions that might come through. I want to share where we've been at NHS England in our journey with AI. In 2019, we published something called the Topple Review. And at the time, our Secretary of State for Health and Social Care asked Dr. Eric Topple, who's the director of the Scripps Translational Research Institute in the United States, and who had written a book on the role of empathy and AI, to give us an overview of the role of this technology and its potential impact in combination with other technologies like genomics, like biosensors, to lead us towards a future delivery of healthcare, which is more personalized, more rational, more efficient to the individual. And over the past few years, as part of my role at Health Education England, or previously at Health Education England and now NHS England, I was looking at the role of digital AI and robotic technologies in education, and some of the recommendations that came out as a result of the Topple Review. And why the focus on AI? Well, we know that the Health Foundation published a report which demonstrated that if people had more familiarity with AI, they were more likely to be positive about its use in healthcare. And that was a study that was done by Ipsos Mori on healthcare staff in the NHS. We've also seen the explosion of generative AI and large language models, which allow us to do things in a much more transformed way, allow us to generate text, allow us to generate media and information. And we generally believe that this will change the way the healthcare workforce works in the future. But when we think about AI, we really think about how it as a technology will protect some of the elements of human compassion and the human-people relationship of healthcare, and allow us to augment the activity that healthcare professionals do, particularly on the backdrop of we know that there are significant challenges around healthcare workforce globally. Through the work that we've done in England around the long-term workforce plan, which is a 15-year plan for how we prepare our health and care workforce for the future, we recognise that if we take no action, there will be a critical shortage of healthcare workforce in England, and that could be up to 360,000. But we are exploring the role of, for example, technologies like AI and automation to be able to help and support us to think about what we do going forward and to support our workforce more widely. We also know that healthcare is becoming more complex. The Health Foundation had published a report that looks at healthcare in England in 2040 and has found that 1 in 5 adults will have a chronic disease, be that a mental health condition, be that something like a chronic non-communicable disease like diabetes or hypertension. And therefore, there'll be an additional burden on the workforce for the future. So how can we utilize artificial intelligence effectively to support the healthcare workforce for the future, but to do that in a safe and responsible way? So I'm excited that we're going to be exploring that today in how we do that by hearing from some of our wonderful panelists. And I will introduce our individual panelists as the seminar goes along. So just to start that off, can I see the agenda? To start that off, I'd like to introduce so this is the format for the day. So we've got Cris, who will be opening for us this morning. And Cris is a policy advisor for the Human Resources for Healthcare within the World Health Organization. Cris has a background in workforce capability and capacity building, having worked for, of course, the World Health Organization, but also previously for the Department of Health in the UK, and as well as across the NHS in England and Wales in some of his activities previously. And he leads and has worked on multiple actions around the EU, around human resources for health enablement, and is currently leading the World Health Organization contribution to the EU's current HEROS JA on workforce planning. And so Cris will give us a bit of an overview in terms of what he thinks are some of the critical factors around the implications around the use of AI for the future healthcare workforce. So I'm going to pass it over to Cris, and then we'll come back and introduce the rest of our speakers for the day. Cris, you're just on mute, it's just there.
Yeah, there you go. That's the first thing about IT. Give a man an unmute button and he'll miss it every time. Thank you, Hatim. Thank you for the generous introduction. Thank you to colleagues for inviting me to talk. And thank you, everybody, for joining this session. I'm going to talk a little bit about the WHO's perspective in terms of workforce, a little bit about general digital health issues. It's not all about AI, in the context at the moment. Hatim, can we go to the next slide? So just a little bit of background about the arena in which I work. I work in 53 member states in the European region with a population of around about 1 billion people. And there are different health trends. There are different health perspectives, digital perspectives across the region. As colleagues on this call and who have joined me in various missions around Europe will know, some countries are further advanced than others. Others are using innovations in ways that perhaps countries in the west of Europe have skipped. And that's a contextual piece that's quite interesting. And the trends of adoption of DH are not universal, of digital health are not universal. Some are going quicker than others, but there is a taste for digital health within the European region, as most countries look at it as a potential solution for workforce challenges and for actually improving quality of care and service delivery, as an accelerant, as a force multiplier, if you like. The COVID-19 pandemic is prescient in all our minds. It's not gone away. It doesn't have pandemic status anymore, but people are still catching COVID. There are new varieties springing up every day, and they are causing, albeit less problematic, but they are causing ill health around the region. And finally, there is that, as I described earlier, a digital health fever around particularly data, the use of data, how to use it. We talk about large language models and the use of AI, and every day I talk to people who see AI as potentially a silver bullet. Our view is that AI offers us a number of potential solutions going forward to a number of problems, but it might not yet be that silver bullet. We need to be careful in the way we adopt and use it. Next slide, please. So a little bit of background about the workforce, because that's my area of work, my passion, if you like. I'm not that exciting in a pub on an evening. So last year we produced a report, the Health and Care Workforce in Europe. It was a booklet, well, not so much of a booklet, it's quite thick, that contained health workforce snapshots across the region for all 53 member states. In that report, we identified some key trends that were going on within the European setting, and this is an example of one of the fiches in Denmark, and we look at broadly raw numbers. We do need to look at this in a little bit more detail going forward, comparing it to health outcomes, making it much more useful in that context. Next slide, please. What we found after COVID, though, having talked about it earlier, is that there is a big challenge with the workforce. It's not just about numbers being trained, it's about retention, it's about a problem that health systems across Europe have in different scales about maintaining the workforce in situ, delivering health and care in a way that is effective, drives population health improvements. Even in the UK, we've seen that recently. As a broad indicator, the average age of death has, for the first time in decades, gone down slightly. So there is an impact on health workforce, numbers of health workforce, and overall investment. And one of the things we need to keep banging on about is that when we talk about health workforce, we're not just planning a health workforce or planning interventions around the health workforce. Health workforce is a critical part of a health service, a health delivery strategy. And when you plan a health delivery strategy, you need to consider the workforce. And that's contextured in the next slide, if you would move on. If you could do the first click for me, because this is a fly-in slide. So the health workforce sits as one of the key system building blocks in the 2006 World Health Report definition of the system framework and the system building blocks. Next click. As you'll notice, service delivery, health workforce, technologies, leadership and governance are all sitting there, and they're very, very interconnected. And going back to what I was saying about 2 seconds earlier, if you are planning any of these interventions, you need to be planning in terms of the workforce. Next slide, next click. And that includes looking at the information available and the financing. These things are interlinked. They don't just happen. Click. And that will lead to a proper marshalling of resources and planning in all 6 domains will lead to improved health, better health system responsiveness, improved social and financial risk, and improved efficiency. Next slide, please. What we know is that the workforce counts, the numbers of workers, okay? And we see in both these charts that increasing workforce density leads to better health outcomes, both in measles immunization, skilled birth attendance. We find that increased reductions in mortality, maternal and infant mortality, and under 5 mortality. These are just snapshots, but they go across all interventions. Next slide, please. What we also know, though, is that the holding on to the workforce is difficult. 3/4 of foreign-born nurses and physicians are hosted by 5 of the countries in the OECD, the United States the most. And what we're finding is that workers are moving across the globe, but it's a complex picture because there's not just a move to the global north, there's a move from the global north to global south, and in between countries within each of those sub-regions. So it's complex, and it's important we get that we understand that. Next slide, thanks. So the shortage of workforce is getting worse in a lot of ways. COVID made that absolutely clear. There's a larger investment in the workforce, which has highlighted some of the challenges. So we do find that the aging health workforce, competition from other employers, migration across regions and within regions, people resigning, and the Great Resignation report that was alluded to earlier, leads to significant attrition for health workers. But an aging population, growth in chronic diseases, growing patient expectations, and managing those COVID backlogs that we talked about is also increasing demand for services. Next slide, please. So we've launched a framework for action that's looking at 5 pillars. And those pillars are really, really important. And they talk about investing, building, supply, retaining and recruiting, optimizing performance, and planning across the domains. Going back to what I said earlier, it's not about planning the workforce in isolation. You need to plan the workforce as part of your planning, full stop. So that talks about planning in the context of overall service delivery, but also those things that countries are doing to improve the service. So that's the utilization of AI, the utilization of digital health generally. And it's important that the human factor is considered. And I will pose a question at the end of this, and it's one that Richard and I have discussed on a number of occasions. But what we do find very often is that AI and IT and digital health, sorry, is applied in some settings randomly or apparently randomly, but in a disconnected way, which makes both the use of digital technologies difficult to maximize and to capitalize on, but also uses health workers exposed because they then become to feel unfamiliar and uncomfortable with using. And that leads to poor patient outcomes. So one of the challenges for member states is can we click through the next few clicks so that they're all highlighted? I think there's one more, team. So so the context in terms of using digital health and core and governance of the health system and stewardship of the delivery of health is important to take a view of digital health across and to invest in the workforce. But that means investing as you supply the workforce, looking at the digital health competencies that need to be built into training, that need to be built into curricula, that need to be considered when rolling out CPD. You can click on the next click as well, I think, team. Perfect, thank you. And the promotion of digital technologies is important in optimizing performance. And I said in the example, and I won't mention any nation states, but the member states that I've been to where the use of digital technology has been assumed rather than trained for, rather than planned for, and led to significant cost, both overruns and spending, misaligned priorities, and wastage within the system. You only need to look at some of the horror stories that we have seen in the past over IT investment in the NHS in the UK to understand that there are challenges there that if they're not properly managed and they're not properly catered for and they're not properly considered, can lead to not just direct costs and poor usage within the system, but also actually create an opportunity cost. If you consider the billions that are wasted on failed IT problems, IT solutions, those billions could have been used to improve patient care. So it's one of those things that I think governments and health systems need to consider is how the IT, the digital health, the AI aspect of it is built into the planning, and how the human side, the workforce side, the patient side is built into the planning of the systems. I've been to countries in the Nordic sub-region which look at the patient in the context of they are part of the user package. And I'm not saying that Nordics get it completely right, but the consideration of the user being both a patient and being a practitioner is key, because both sides of the coin need to be built into this. When planning, then, you need to strengthen the capacity of HR units to deliver healthcare services, but strengthening them also includes considering their role within an IT setting. The HRH information systems that people use at the moment are such that they're generally misaligned across the region with the health information systems, and there's a misunderstanding about what an HRH information system can do. They have a misunderstanding about a health information systems do, but they are repositories of data and information, and they should be used in the planning of the service delivery, and therefore the investment in IT, digital health and AI, and in technologies other than the pharmaceutics, etc., but also in the workforce, and understanding what the capability of the workforce to deliver services is. Inherently, that means that perhaps we need to move away from some of the professional models that have been accepted for many, many years. And we do find doctor-led services still predominate across the regions, but taking a look at the capabilities that the workforce requires to deliver services means that perhaps we're more able to think about multidisciplinary teams enabled by technology to deliver services more adaptively and more flexibly to improve patient outcomes and to make sure patients are dealt with in more timely fashions. We see waiting lists in most countries, and foregone care as a result of COVID is a classic example of this. Next slide, please. So when we're looking at optimizing the performance of health, workers need to be focused. The technology should be responsible to patient and health worker needs. The patient and health workers should be involved in the design. They should support health patients and avoid transforming the current complexity into another digital complexity that people don't want, can do without, and actually will be unhelpful and probably lead to poorer patient outcomes. You need to think about the technology and the use of health workers when you're looking at patient pathways and the care models, and processes should be a starting point to anchor those digital technologies. So think about what it is people are doing, and how services are delivered, and how services are going to be improved based on other technologies, not just digital, but also how digital can streamline process that exists. And there are examples in Spain. There are examples in Scotland, in the Nordics, in Eastern Europe, where technology is becoming more and more useful. But it's still early days. The role of AI is, comparatively speaking, a newborn, and we need to be very careful about just rushing to the door and saying, yes, all our solutions are going to be based around AI. We need to think about, therefore, building digital health and AI into the broader health system, not in isolation. It's part of a symbiotic relationship. It shouldn't just because they're available. We should think about the effectiveness of them. We've got to avoid the move away from high touch of workers. And by that, we need to think about that human factor I talked about earlier. A lot of patients actually get a lot of health benefits from interaction with other human beings, and therefore we've got to avoid taking away that interaction piece and move it to a much more remote and high-tech approach. I remember speaking to someone in the Cabinet Office once, using a UK example, who was telling me that potential solution could be just to give every older person in a care home an iPad, and they could look after their own care. And it was a really challenging conversation to have, but you need to sometimes just push back on those ideas. Yes, iPads could be quite useful, but think about how patients interact within the system and use IT appropriately. Finally, I think the capacity of health workers has to be built from the ground up. So we have to integrate all these new technologies in the training that they're doing when they're undergraduates. We need to consider what it is they're doing around developing their competencies there, and we need to build it into continuous professional development. Health technology, digital health, AI will evolve, and it will evolve very, very rapidly. Yesterday's training may be yesterday's training, and for those who developed CPD and education packages need to be aware of that. Next slide. So finally, our digital action plan for the region 23 to 2030 is based around promoting digital health systems to improve health at scale, looking at the region as a whole and looking at it as in sub-regional issues as well as individual countries. And we're looking to support countries and leveraging up and scaling the transformation for themselves to improve health improvements and aligning those digital technologies with investments, health system needs, and workforce requirements. And more importantly than all of that, probably the patient needs as well. And we have to respect the values of equality, solidarity, and human rights. That seems like a very trite statement to make, but the ability of AI, of digital health to impact and dehumanize the whole process needs to be adequately considered when we're talking about rolling them out big scale. Next slide, please. So we have 4 clear strategies that we're going to be working on, and through 18 regional focus areas, and there are 21 illustrative actions. I'm not going to go into those, but we're taking it seriously, and these are all available on the website for the WHO Euro website. Next slide. Finally, the strategic objects are to develop norms and guidance and technical products. We are looking to support countries, and we'll be looking at horizon scanning and scaling up. And we will be looking to leverage network and knowledge exchange between countries. We're doing that at the moment with 6 nations from England, Scotland, Sweden, Macedonia, Romania, and Georgia, in a collaborative looking at primary healthcare and how leadership and technology can be properly applied and leveraged there. We will do similar projects across the region. Countries and practitioners and populations have the solutions. We should listen to them. Next slide, please. So I have to leave you one question, and Kay, I do apologize for taking a load of time. I've just seen the chat coming up saying Cris is talking too long, but we've been asked to pose a question, and the question I'd like to ask you is, I just want your views on the statement and in the context of artificial intelligence. Just because we can do something, should we do it? Is it AI always the best way to go? Is it always the best option for patients? Thank you.
Thanks, Cris. Some tremendous takeaways for me from your talk, particularly the composition of the healthcare workforce globally. I think is fascinating, but also fascinating to see the role of migration of healthcare workforce in the future. And really good to see the work that's being done by the World Health Organization in this space. We, NHS England, have done work around digital capability, particularly looking at artificial intelligence and building a capability framework for AI and digital healthcare technologies in the last year or so. I know Natalie, who will be speaking later on, has done similar work in Canada. So it's great to see that coming together from a kind of intergovernmental organization point of view with the World Health Organization. And I'm sure there were already some questions in the chat to pick up later on. And a reminder that there is a Q&A function to allow you to ask those questions, so please do engage. So we now move on to our next speaker. Our next speaker is Firth-Butterfield. Kay is CEO of Good Tech Advisory LLC and formerly the inaugural head of AI at the World Economic Forum and an expert in governance on AI. She has a background as a barrister, a former judge, a professor and technologist and entrepreneur, and is from the UK, which is wonderful to see, but currently based in the United States, and has worked on various initiatives like co-founding the Responsible Artificial Intelligence Institute, and was the first chief AI ethics officer for the world. Kay is going to give us a sense of international governance and provide that experience with a focus on what that means for us in healthcare. It's clear that we need to learn from other industries, and Kay's ability to be able to work across industries, I think, is incredible and really respectful, and really looking forward to hearing your opinion on this.
Thank you, her team. And thank you, Cris. You stole, of course, my question. And one of the things, because that's one of the things I often finish with saying, just because you can use AI, should you? So very important that we start with that if we're going to look at governance and trust in artificial intelligence. And so I think that my question to all of you would actually now be, what do you think about governance? Do we have enough? Is it getting in the way of innovation in your sector? What we know is that the British government, despite hosting the AI summit, doesn't look as if they're going to move to sort out what I would call some of the major problems of AI through regulation anytime soon. And so that actually leaves the question of regulation. How do you use AI in your practices? Down to you. Is that the optimal as far as you're concerned? So bear in mind that question as I speak. I actually felt that 10 minutes was enough time, that you didn't need slides, because we all know that even today we have a 10-minute attention span. So the other thing that Cris stole from me was the silver bullet. I don't think that AI is or should be considered to be a silver bullet. And that is truly important when we talk about one of the other things, which is the financing of AI. Again, Cris pointed out that we tend, or there are good examples of healthcare getting IT really wrong. And so I urge anybody who's thinking of deploying AI, who's thinking of buying AI, to really think through the governance issues that we have. So I want to start with a personal story. A lot of people, when they hear me talk about governance all the time, thinks, oh, here is a Luddite. She doesn't believe in technology and she wants to slow us down. That's actually not true. And technology recently saved my life. I went for my annual mammogram and was told that I had breast cancer. Mammograms are an extremely good example of the use of AI. We know that there are some results that show that mammograms read by AI can pick up cancer much earlier, up to 4 years earlier than the actual cancer growing. And so I think that that's something that, you know, we should be thinking about when we're looking at where do we deploy AI. Let's deploy it in places that A, are proven to work, and B, free up the nurses and doctors to do the job that we as patients want them to do. We want to be talking to our doctors. We want to be understanding our treatment. We want to have personalized nursing. And so thinking about the things that AI can do in note-taking and things like that are, to my mind, the places that we should be now really saying, is AI fit for the purpose? But first of all, what you're going to have to do is to prepare your workforce. There was a recent big survey in the United States of just the workforce in general. And it showed that 2 out of 5 people were frightened of losing their jobs to AI, as a result of which they were looking actually for other jobs. They were going to be leaving their employers and looking for other jobs so that they weren't put out of work. We need to take everybody along on this journey with us, especially as we have such a shortage in healthcare, both in the United States and in the UK and other places in the world of healthcare professionals. So why I wanted to just mention the big thing of, okay, AI, but keeping your staff depends upon them really believing in the mission, caring about the mission. And what's the mission? The mission is patient care. So if we can free them up to do that thing that they want to do, the reason they came into healthcare in the first place, then that's a great use of artificial intelligence. So again, back to my personal story, I ended up with 2 surgeons for my breast cancer. And both of them, the first time I saw them, gave me their mobile phone number and said, text me if there are any problems. Well, there's a technology, but having that access to my surgeons, which I of course didn't abuse because I know they're busy people, just gave me such satisfaction as a patient. And I think that's what we need to be thinking about when we're thinking about deploying AI. How do we make that patient health professional relationship so much better? And how do we use AI to underpin it? So let me look at governance of AI. First of all, procurement. So the UK and the World Economic Forum back in 2019 actually produced some guidelines for good procurement of artificial intelligence across any sector. And that actually came into force in July 2020. So if you're in England and you're thinking of procuring AI, there are actually some guidelines that you can use where you can actually go there and you can then ask your suppliers questions. You know, what about accountability? What about explainability? What do you do about privacy? Where does the data come from? All of those key questions. And we're all talking about generative AI, but please, please, please go back to the issues that we had with AI before we had generative AI. And then just know that generative AI puts all those issues on steroids. So when you're buying, you must be very careful about who you buy from. There's a lot of this, back to the silver bullet thing, there's a lot of people who are saying, I am an AI company. That gets them money, but often they're not AI companies. And then think about the data. Have you got the data that is actually going to enable the use of the AI system? And I come back to, for example, the data for heart attacks. What we know is that the bulk of the data on the web about heart attacks and treatment of heart attacks is actually found about white American men over 55. That's actually not very helpful if you're sitting in Kenya. And so you have to be really thoughtful about, do you have the data that is rich enough to deploy artificial intelligence? And unfortunately, in many countries in the world, you just don't. So building your own data is actually important. A generative AI model is only going to use what's available. And what we know is available is generally useful to white men and not so useful to all the rest of us, unless it's specifically targeted to something like breast cancer. How to make a good chatbot. We worked with Rwanda and India to actually create a chatbot that does triage. And it was a ethical AI chatbot. So there are examples out there of how to do it properly. And so really doing this, getting the governance right and asking all the right questions will save you money in the end. It'll not only save you money, but it'll help your professionals in the healthcare system to have a better experience of deploying AI and freeing them up for customer service. So to conclude, I think we need to spend the money on AI in prevention and giving medical professionals back the time that they need with the patient so that they can answer people like me's texts. That if I think about the amount of time that was saved by that professional by giving them my text, by giving me their text, I didn't go to see them when I would otherwise have gone to see them. So I know for a fact it was probably 6 hours of their time and considerably more of my time. We need to be thinking about not just artificial intelligence, but some of the tools that are at hand now. Thank you, Hatim.
Thank you, Kay. I want to start by saying it's really nice of you to be vulnerable and share your own personal story, actually, because I think that's really important. And it reminds me that health is really critical to all of us as humans. It's a significant part of our lives. It's a significant part of our friends and families' lives. And therefore, if we're going to use artificial intelligence, we must do it right. On the matter of governance, it is a very complex issue because we know there's governance across international governance, there's governance in terms of what might be happening within the country or within the region, and technological governance as well. But there's also things that we need to consider in terms of regulation and governance from a domestic point of view, in terms of healthcare specific. And one of the things that exists currently in England is the AI and Digital Healthcare Regulation Service, which provides advice to adopters of technology and developers of technology in terms of what steps to follow to make sure you are following the right pathways to get the right sign-off. And at Health Education England and at the NHS AI Lab previously, we did a piece of work to look at how we build confidence in healthcare workforce around AI. And as part of that, there's a key element around the governance, the liability, and the regulation of these technologies, and being able to validate them appropriately, because we know that healthcare in itself is biased. And what we need to try and do is move away from that bias and utilize AI to help us move away from that bias. But that is going to be very critical to the future, both of healthcare in this country, but also globally. I'm now going to move us on to our next speaker. And Cris pointed earlier to the impact of the COVID-19 pandemic, and how actually, whilst we're not considering it a pandemic anymore, it's very much still around. So I'd like to say massive thank you to Natalie Mayerhofer for stepping in at a very late notice, because her colleague unfortunately contracted COVID-19. But having met Natalie before, I have no doubt she's going to be an excellent presenter and be able to give you a really good sense of the work that they're doing. So Natalie is the Deputy Chief Learning Officer at University Hospital Centre Montreal Health, and they have founded the world's first hospital-based school of artificial intelligence in healthcare. It's been actually really exciting over the last few years to be on a journey with Natalie, to share some of the work that we're doing in the NHS in England, and then some of the work that Natalie and her colleagues are doing in Montreal, and to be able to develop that learning, because actually we did some work to develop a capability framework for AI. It's something that Natalie and the team had already done beforehand. So it's wonderful to hear of that work internationally and be able to learn from that work internationally. Natalie is a former evaluation manager for Cambridge MIT Institute, a former manager of planning and institutional analysis at McGill University, has significant experience across academia, across healthcare, and will give us an overview of the work being done in the hospital that she works as part of. So over to you, Natalie.
Thank you for that lovely introduction so much, Hatim. Thank you for everybody else who's on the panel today. It's amazing to be able to hear your different perspectives. I'm just going to do a quick overview of what we're doing concretely here at the hospital to better support healthcare actors to thrive in what we refer to as an AI healthcare environment. So to start, I'd like to talk to you a little bit about what the CHUM is, so the Centre Hospitalier de l'Université de Montréal, and you can pass over to the next slide. We're an academic hospital here based in Montreal, which means we have the mission to improve the health of the adult population, but there's other elements to our mission too, notably research, teaching, innovation, and patient partnerships. And we talked a lot about how patients need to be at the core of everything we do. And here at the CHUM, we really truly believe that. We welcome over 500,000 patients annually. We offer specialized and highly specialized care in the region of Montreal, but also for the rest of the population here in Quebec. And we play a decisive role in improving the health and well-being of the population. And we're part of a very large international network of academic hospitals as well. I'd ask you to move on to the next slide. As the CHUM's Department of Teaching and Learning, our mandate is to build the capacity of healthcare workers to really integrate new knowledge and innovation into real environments, a real hospital, to improve the health of the population, which means that our learners are the 19,000 members of our community, researchers, managers, patients, students, and we love bold and innovative projects. As a little example, in 2016, we built one of North America's, so certainly Canada's largest simulation center. It is accredited by the Royal College of Physicians and Surgeons in Canada, one of the few, and we're very proud of it. And yes, we're affiliated to the Université de Montréal, but we have a lot of other partners as well. So I won't talk too long about all the various healthcare challenges in the next slide that we're facing, because you've touched on them already, notably Cris and Kay. Thank you very much. So the complexity, the chronic diseases are definitely increasing. It's a significant issue, and AI, as you mentioned, isn't necessarily a silver bullet. It's one solution compared to many others, along with many others. And one of the issues we're facing, however, with AI and digital technologies in general is that they're increasing and they're developing at such a rate that they've actually surpassed our capacity to adapt. So we really have to think about new ways to teach, to learn in this context, because let's remember, there's labor shortage, but there's also a low health literacy of the adult population. Even here in Canada, 60% of adults are not able to make a decision based on their healthcare. And we're adding to that the reality the new graduates feel unprepared for AI, despite the fact that doctors, for example, do expect AI to significantly transform their profession. Next slide. So these challenges really made us realize, as experts in teaching and learning in the hospital, just how critical that has become. Yeah, we could develop skills, organize symposiums and talks, disseminate knowledge as usual, but we can also do a lot more to create what we refer to as real value for the population, to reduce costs for our teams. We mentioned not wanting them to leave, definitely important to support them through this transformation, but to accelerate innovation, but most of all for our patients who deserve the best care and services. Next slide. So in 2018, as Qantm mentioned a little bit in parallel to the work that they were doing, we decided to launch the School of Artificial Intelligence and Healthcare here at the hospital to tackle the challenges of the digital transformation, but also support our healthcare actors by developing hard skills, but also human skills. We were the first to focus on this kind of human development of these human capacities and organizational capabilities as well, to integrate AI in a human-centric, ethical, and responsible way. And to do so, we actually co-designed the entire school with over 150 collaborators. This was in late 2018, early 2019. So when the TOEFL review came out, I mean, Qantm mentioned it being fun to talk, but honestly, we opened it up and went, oh my gosh, that's amazing. They came up with the same recommendations and they noticed the same things as we did. So it was amazing to know that across the pond, we had come to similar conclusions with beautiful nuances as well. So as a school, our learners, as I mentioned, are all the healthcare actors, because if you want to really truly integrate AI in healthcare, everybody must be involved. No one must be left behind. So doctors, nurses, but also managers, students, industry partners must be included in this transformation. Next slide. To build an educational program, one of the first steps is determining which are the skills that you want to develop. And you don't want to think about which are the skills I want to develop today, but which are the skills that I'm going to be building on and which will still be relevant 10, 20 years from now. And our competency framework is therefore the cornerstone of our entire programming. That's its foundation. And as you can probably notice, those skills aren't just technical skills. They're also human. So to change your status quo, you need what we refer to as a growth mindset. To lead through transformation, you have to be able to engage, inspire others around you. And to benefit patients, you really have to learn to make mindful choices with and not necessarily just by AI. But 16 competencies is a lot to develop. That's a lot of development. So it was important to prioritize and figure out a way of organizing and focusing our energies. And so how did we do it? In the next slides, I'll give you some concrete examples. So we targeted different learners, which I'm going to present to you. And because I like to make things concrete, I'm also going to list some examples of what the actual output was. And to keep it simple, I'm going to stick to a theme. So we're going to be talking about AI in oncology or for cancer care. So to start with, AI isn't perceived as a need on the field. So if you're talking to somebody, you know, at the ER and you talk to them about AI, they're going to look at you. They may look at you like you're a bit of an alien. So it's important to be able to start by building awareness. And we developed a bunch of tools and activities for healthcare actors in order to do that. So We partnered with the Canadian Cancer Society. We surveyed over 800 patients and caregivers across Canada to understand what their expectations and needs were in terms of learning about AI. We did the same thing with over 300 oncology professionals here in Quebec. We organized a bunch of lunch and learn conferences. The latest was on how AI in pathology is helping to better diagnose cancer. We did a publication watch with our medical library here at the CHUM. We're very fortunate to be able to count on them. And a whole information kit was actually designed for patients and their caregivers, designed along the entire disease continuum, including ethical and AI considerations with the experts here at the Lise Langlois, the Observatoire here in Quebec, which specializes in ethical AI and responsible AI, because they're really at the heart of this transformation. And next slide, we're going to go through them fairly quickly. So once you build awareness, you need to start focusing on AI curious healthcare professionals. So the ones that are actually easy to get into the room. So for them, what we did is we curated existing content onto our website. 16 competencies is a lot if there's material already available through either a partner or online that's easily accessible. Curated. We developed courses, example here with the Canadian Cancer Society, which was in 3 parts available to all professionals, healthcare professionals here in Quebec, and is now available on our website, so you're welcome to go see it. Although Astérix, as we would say here in French, most of our content is mostly available in French. So there were also educational podcasts, so not regular podcasts. Really think about a course, but in a podcast format for intermediate, but also experts as well. And we also developed guides to just showcase AI leaders, their projects, and what we're doing in terms of oncology here in Quebec. For teaching and training professionals, we developed a bunch of tools and guides that are based on our competency framework. So we're really talking about training the trainer programs. We're an academic hospital. Those trainers are not prepared for AI. They're not prepared for AI as trainers. They're not prepared for AI in their field. So it's critical to be able to support them to make this information more accessible and for them to be able to train those around them as efficiently as possible. And finally, for AI project leads, so their needs are completely different. So the pioneers who are already testing, researching, developing, implementing AI, they don't necessarily need the same introductory course. So with them, we have more of a collaboration. We promote their projects. We work with them to showcase their work, to understand their needs. We offer them opportunities also as content experts in our podcasts, our conferences, our tools. As well, they're parts of our scientific committees, which we put in place for all our projects, different ones as well. And with them as well, we manage and support communities of practice, since it is still niche. It's important to get them together as much as possible, including a new one in AI and oncology. And finally, I'd say they really do need a lot of networking opportunities through various events, but we also help them connect with key stakeholders. So sometimes you might be talking to a researcher and clinician who says, I really want to work on an AI in oncology project. Do you know somebody else who's working on it? And you remember that you met somebody or you have friends at the Canadian Cancer Society. So you try and facilitate those links to the best of your abilities. And so I'd ask you to go to the next slide. Oh, it's funny, strange. One disappeared. Can you go back a notch? Oh, weird. One's gone. Either way, that's fine. What I was going to say essentially is that that's actually just one example, oncology, among a ton of other things that we actually develop for in terms of specific topics for AI integration in healthcare. And since 2018, we've delivered many lunch conferences and events to create awareness, training to develop skills, communities to better innovate. We've curated content, as I've mentioned, podcasts as well, but also a variety of educational tools. Our results are significant. I am not the boasting kind, but we're pretty proud. We're talking about over 45,000 participants to our various courses and activities. When we're talking about over 10,000 views of our tools, which we're very proud of here at the CHUM. So what's next? exciting experiential learning activities with amazing partners who also who have different expertises. So for example, innovation in education. So we're at the intersection of education, AI, and healthcare. So it's fascinating to be able to learn from these various fields. So definitely research on teaching and learning and healthcare we're going to pursue. Lots of knowledge exchange and of course plenty of grants and collaborative projects. Which means that that would bring me to the end of my part. And again, so to do what the others did, perhaps my question to you is, it may be easy to try and think that what we need is an intro to AI course or learn to program in Python, which are amazing things to learn, and learning is so important. We must keep learning all the time, but try and think about the skills that you're going to need 20 years from now, when AI has helped us out on so many other levels, and start focusing on how to develop those skills in your team, but for yourself as well. Thank you.
Thank you, Natalie. Wonderful presentation, and really interesting to see your learning strategy, because there are some parallels to some of the things that we have been looking at over here. And the call I've seen in the chat, a conversation around how we build the right skills amongst the workforce and how we do that through education and training, and something that we have explored. I really like your call for how we do this for a multidisciplinary workforce, really spanning both the clinical workforce, but also the non-clinical workforce. And this is a huge challenge, because we do need to bring everyone up to a certain speed, and some will be kind of a baseline and others will be in more advanced knowledge. And how do you create that interdisciplinary learning in a hands-on way, an experiential way, I think is really important. A reminder that if they have any questions, particularly around that education and training part, please do pop those into the chat. So next up, we've got Dr. Seth Dobrin of Qantm AI, who's the founder and CEO of that organization. Seth is actually right next to me in the room, which is wonderful. So I'll just be turning the camera over to him when we were about to start. Seth has an incredible background in industry, and Natalie presented the quintuple aim, and thinking about kind of how you deliver healthcare systems in the future, thinking about cost savings and efficiency savings on top of how we support the workforce and improve population health. And Seth has tremendous experience in the value and in the form of cost savings and new revenues in industry. He was Chief Global AI Officer and Chief Data Officer for IBM previously, has also been the president of the Responsible Artificial Intelligence Institute, and has a background across industry from venture capital and private equity in the form of the use of artificial intelligence, and now does a lot of significant work in the Middle East and across the world. And I think it'd be really exciting to get a viewpoint from Seth that what we can learn from industry as we explore this in the future in healthcare. So over to you, Seth.
All right, thanks to Tim. So thanks, Natalie, Kay, and Cris. I feel like I need to change all my slides after having you guys go. There's a lot of overlap, but you know, I think it's good to see you all. I also just interestingly for this conversation, my training's in medical genetics, way back towards the end of the Human Genome Project. So I understand the space quite well, and hopefully you'll see that I'll be able to frame up the content in a way that's relevant to healthcare. I'm not moving the slide, sorry. So I always start my talks by, you know, asking, are you piloting AI, and having people raise their hand. You know, it's you know, so raise your hand in Zoom if you're piloting AI, and then go to the next slide. You know, keep your hand up if you have AI in one line of business. And then if you go to the next slide, you know, keep your hand up if you have it deployed across the whole of the organization. And the reason for this is usually, you know, the first question, most of the room have their hand up. By this last question, it's usually 5% of the room that has their hand up. And, you know, there's some interesting reasons why we see this lack of deployment across the whole organization. And also, interestingly, the analysts do a lot of reports, and if you ask them, self-reported CEOs, you know, 30% of them will say that they have AI deployed across the entire organization. So there's a huge gap from what the CEOs believe and what their organizations believe. You can go to the next slide. And so, you know, within that context, let's start by defining AI. AI is a nebulous term. and means different things to different people. I think I'm part of that from my time at IBM, where AI was just a marketing term. And so what is AI? If you go to the next slide. So just to really level set, AI is, you have statistics, which, is machine learning or is based on statistics. The important part of that is that statistics is probabilistic. And so since machine learning is a type of, uses the same algorithms as statistics, it's also probabilistic. And in fact, what we think of as machine learning is just taking statistical models that we've been using for decades and leveraging new cloud and computing storage and compute capabilities to continuously learn, so continuously update those statistical models so they're no longer static. And deep learning is a type of machine learning. So traditional machine learning that we think of is not black box. When you hear black box machine, black box AI, that is deep learning. And within deep learning, you have this whole concept of pre-trained, also called foundation models. And these are a type of deep learning model as well. And one of the reasons I like to bring this up is that because pre-trained or foundation models are types of deep learning, which are type of machine learning, which are a type of statistics, they're all probabilistic. And that leads to some challenges that we're seeing today. If you go to the next slide. And so within pre-trained models or foundation models, generative AI is one type of those models. And within generative AI, we have some capabilities that probably most everyone on the phone has, or on the call has heard about. Certainly Kay, Natalie, and Cris referenced them. So we have large language models, which is ChatGPT, OpenAI, Anthropic, Facebook. Everyone's got their own large language model. Within language, you have different types of applications. So there's lots of things that can be thought of as language. So obviously text and speech. Code is a type of language. Genetics is a type of language, as is combinatorial chemistry. And so these are all thought of as language. So the same technology that is used in ChatGPT can be used for a lot of medical advances. In fact, during COVID, we saw the first applications of this where some of the small molecules that are coming out now to treat COVID were identified using generative AI, large language models specifically. And there's an interesting anecdote where there was a researcher who was doing research using large language models type technology to identify small molecules. And one of the factors in there is, do you want it to be toxic? And so that's a 0. The answer to that is 0 or near 0. And he was invited to a conference to talk about the risks of generative AI. And he changed that 0 to a 1. His graduate student went home. He and his graduate student went home. They came back the next morning, and there were about 1,200 toxic chemicals that were identified. About a quarter of them were more toxic than sarin gas. And those quarter, about half had never been identified or even thought of before. And so while there's tremendous promise for these technologies, there's also significant risk, even beyond what was talked about. Other types are image and video and 3D generative AI. And so if you go, and again, because they're statistical models, they're probabilistic. Now there's, when we think about, and you can click again, there's a build here. So if you click again, oh no, go back. When we think about generative AI, we think about specifically language models. We think about conversational AI and content creation. And these are two incredibly powerful capabilities, but they don't go too far beyond what we've been doing for years with traditional, more, not traditional, but more advanced chatbots. So chatbots that actually leverage NLU and NLP. The real value, if you click up, go back to the green circle. The real value is in content discovery. So generative AI, and again, specifically large language models, are really, when push comes to shove, they are really just powerful classification engines. And so they sift through a lot of content, they make sense of it, they do what's called entity extraction. And so they create a great opportunity for organizations to actually make sense of content. And so what do I mean by that? So we all have SharePoints, Google Drives, Dropbox that contain a whole bunch of stuff. But we have no idea what's in it, really. Even an individual loses track of what's in their content store. So imagine being able to make knowledge out of that content. And you can, in fact, do that today. It's also really powerful for education and training and search. And so if you click again, the other capability that's not really thought of or used very often is simulation. So these tools have incredible power to do simulations at scale like we've never been able to do before. So think real digital twins that can be constantly updated, scenario planning, materials discovery, synthetic biology, synthetic chemistry, like I talked about. So really big power and capability to do simulation. And so when you're thinking about generative AI, it's really important to think about those other components of it as well. If you go to the next slide. And so, what's your plan to use AI? Click again. So other organizations are likely starting, as I mentioned. I think one of the things they're doing is they assume a level of maturity. They have AI, existing AI teams that are identifying use cases. They're using existing governance and accountability structures. They're primarily using commodity models, and they're leveraging existing technical capabilities. Now, go to the next slide. If you're doing this like they are, it's all wrong. It doesn't really work, which is why we see only 5% of organizations deploying AI. And if you can't get AI right, how do you expect to get generative AI right? So there's gaps in readiness, not just from AI capabilities, but especially when we start looking at generative AI. Use cases really need to be tied to business goals. And so Natalie alluded to this a little bit. Oftentimes companies call me up and they say, we need help with identifying a generative AI strategy. And I say, sure, I can help you do that. And then the first thing I say when I show up is, you're asking the completely wrong question. The question is not, how do I use generative AI? The question is, what are my business goals and how can generative AI help me achieve those goals faster? Or actually, what technology can? AI or generative AI inevitably is one of those. From a governance perspective, there are unique challenges with generative AI that don't exist in AI, and most companies don't govern AI well already. And then the selection of models needs to be use case specific for a variety of reasons. And the existing talent really doesn't understand this technology. In fact, if you listen to Sam Altman, even the experts don't really understand this technology. And so we need to be very careful about how we approach this. And the technology literally changes weekly. Now you can go to the next slide. And so, generative AI has the potential to literally revolutionize every industry. Can you go to the next slide? And you can just click twice here. So if you look at McKinsey, they're saying it's going to add $4.4 trillion to global GDP. And that's on top of their estimate that they came out with AI in general. And it creates a 40% increase on the economic total potential of AI if you include generative AI. So it was 3.37 for just AI. So with all of AI today, we're looking at $7.7 trillion in total GDP. I just realized that it's always the same number with a decimal point with McKinsey studies. You can go to the next slide. And so, in that context, is AI nirvana here? You can go to the next one. And Harvard Business School and BCG just came out with a great study that kind of leads us in the direction. And they've identified two types of use cases in this study. So tasks that are easily done by AI, they call inside the jagged frontier, and tasks that are beyond the current capabilities of AI, and those they call outside the frontier. And if you go to the next slide. So what types of use cases, and there's two builds here, what types of use cases are, applicable to inside and outside the frontier? So outside the frontier, today's generative AI capabilities are analytical. So think math, compare and contrast, things like that. Whereas inside the frontier are more creative tasks. So content creation, programming, computer programming is creative, things like that. And the study with BCG they did was BCG committed 1,500 had 1,500 consultants volunteer, and they had very defined experiments. And I can provide the paper to Richard so he can distribute it, where they go into the exact use cases. But it's a very good scientific study, so actually scientific. You can go to the next slide. And they found that there are two different classes of individuals that use generative AI. So one is a centaur, so the fine line between human and horse, in this case, human and machine. They work together, but there's a division of labor. There's a distinct interface of collaboration. And then there's the cyborg, where there's deep integration between the human and the machine. There's a constant interchange, so the human doesn't go to the AI and then walk away and do something else. And there's seamless collaboration. And interestingly, people in this cyborg, treat it as if it's, another human being. And I operate this way as well. Say please and thank you, tell it did a good job. And so they actually interact with it like a human. And you can go to the next slide. And so if you look at the cyborg persona for those inside the frontier use cases, you find that they're able to get 12% more tasks done. They do it 25% faster with 40% higher quality. And even within cyborgs, when you look at tasks that are outside the frontier, they actually get 19% fewer tasks done when they use generative AI. You go to the next slide. And so, maybe, even in that context, maybe generative AI isn't ready for a variety of reasons. You go to the next one. So it's not safe for business. You can click again. And why isn't it safe for business? Well, it lies, first of all. And what do I mean by it lies? This is what we think of as hallucinations. I think most people have heard about that US lawyer who used ChatGPT in a case and asked it for case law. He decided not to check it, which I think is unethical for a variety of reasons. I think they're even supposed to check their paralegals' work. And the cases were completely made up, so had no basis in reality. You go to the next slide. And if you look at a study, you can click twice here. If you look at a study that came out of Stanford, I believe, they found that even when these tools are able to give references, 47% of the time, it's like that case with the attorney where they have nothing to do with, they're completely fabricated. And 46%, and these are not overlapping, they're inaccurate. So they may be contextually correct, but they're not the whole story. And so what that means is when these models are able to give you answers, they're only correct answers or correct references 7% of the time. So that is a huge challenge. And this is in the consumer version. There are ways to fix this or mitigate this in organizational context. You can go to the next slide. And so on top of that, generative AI has regulatory issues. Next slide. The legal and regulatory issues are not yet even remotely understood. There's not really any good regulation around it. And if you look at even the EU AI Act as a framework for regulation, there is not a single generative AI model that's even close to being compliant with the EU AI Act. None of them, they've all violated for the most part in some way, likely have GDPR and CCPA. And so what does that mean? And I think we're starting to see some cases that are coming forward with that. You can go to the next slide. And there's, generative AI has some dirty little secrets. If you go to the next slide. So for every 20 prompts you do in ChatGPT, on average, you consume 500 milliliters of water. If you go to the next slide, training these models is the equivalent carbon consumption or carbon production of 125 round trips between New York and Beijing. It's a lot of carbon contribution. You can go to the next slide. And so what do we do now? And what are some use cases? And actually, Richard's going to send out the slides, look at the use cases, but I think this is a workforce conversation. And so I think, I only have a couple of minutes left too. I want to talk about jobs, and we didn't really directly address jobs. So I agree with everyone that says in 10 years' time, we'll have a significant number of net new jobs. And it's equivalent, if you think about it, to the Industrial Revolution or the Agricultural Revolution. The difference is, I said in 10 years' time. Both of those previous revolutions took 50 years. And you saw a lot of jobs go away, but you had 2 or 3 generations to transition people out of jobs. It's predicted that we won't even have a single generation. And another difference between those other 2 revolutions and the generative AI revolution, or just AI revolution, is we're looking at higher skilled labor now. So not only are we looking at blue collar, which traditionally we think about as blue collar jobs, we're also looking at high skilled white collar jobs. So, Cris talked about patient triage. What does that mean for nursing and physicians? You're looking at paralegals being put out of jobs because they'll do things, you'll need fewer paralegals to check the work. And so you're going to see occupations like that where you have high skilled labor. Now, nursing, it's actually a good thing because we have a huge nursing shortage. And so can we make that happen quicker? But, going beyond the medical profession and things like nursing, it's potential, a bloodbath, a jobs bloodbath over the course of the next 10 years if we're not very deliberate and careful. And you saw that with the writer's strike, the actor's strike. You're seeing that with the auto worker strike in the US. And so we need to be very deliberate about how we transition. And unfortunately, in the US specifically, the areas where you're seeing the change now are really the only heavily, unionized or organized industries that are likely to be impacted. So, you have flight attendants and pilots that are unionized, but they're not really going to be impacted too much. And so, we need to be very deliberate about how we approach that. And so I'm going to wrap up there. Not many people, I think, there's a small number of us that are very straightforward and honest about the transition. And so I just wanted to bring that up.
Thank you, Seth. And Seth, of course, will be around for follow-up questions and discussion going forward. It's really interesting to see the potential impact of generative AI on top of what we are seeing in terms of classical AI. And some of the work that we did at NHS in the past is trying to understand the impact of classical AI and the impact on the workforce for the future. And I think that critical point around the healthcare workforce being short is a really interesting nuance. But then what do people do differently? And what new skills do people need? And I think that is particularly the key of what we need to be addressing and looking at in the next kind of 5 to 10 years. And then thinking about the longer term impact and the learning from other industries as well. And also thinking about how we protect that part. And there's been a lot of conversation in the chat about compassion and that human interaction between people is what people want from healthcare. So can we protect that with the use of these technologies? And I truly believe we can. I'm going to now bring us back to our final speaker for the opening part of the seminar. And I think we've had a really interesting conversation across the role of potential AI and generative AI in healthcare and its impact on workforce. And earlier we heard from Natalie in terms of how we build the right skills in artificial intelligence amongst the healthcare workforce and the work they've been doing there in Canada. And now we're going to hear from Willie Ngumi, who's the Deputy Digital Learning Director at the Institute of Capacity Development. Willie has a strong background in technology and business development and has worked across the private and the public sector. He has experience and skills in healthcare and health system strengthening, behavior change, communication, human-centered design, and digital identities, particularly focusing on underserved communities, and has worked across global roles as well as the regional roles in the work that he's done so far. And what Willie's going to do is give us a bit of a flavor in terms of practical use cases, going beyond the buzz of artificial intelligence, but actually where is it being used right now and what can we learn from its application so far? So thank you, and over to you, Willie.
Thank you very much. Good morning, good afternoon, all of you. Thanks for the introduction. I'll just go quickly through a couple of slides, and I really appreciate the speakers who've gone before. Really touched on similar themes as I will share. So I'll pick on some of what you shared, but mine is more of a reflective conversation. So you can proceed to the next slide. Looking at artificial intelligence, and when I talk about buzz, technology, always creates opportunities as it evolves. And the opportunities are cross-cutting. When you look at computing, capacity increases in leaps and bounds. The number of inputs for data and sources of information has increased. All sorts of sensors, data, and the internet as well. So the possibilities continue to increase, and that sort of creates a buzz. There's an excitement around new technologies, about new possibilities that always comes up. You can go to the next slide. And I was looking at how do we go beyond the buzz. In the recent past, you had technologies like Bitcoin and crypto that really created excitement. You had a lot of talking about how they can be used in the health sector. And AI is also one of those technologies that is really picking up speed. And again, when I talked about possibilities, is when technology presents sort of an open canvas, then there's a lot that can be done to try and figure out how do we best harness this technology for what we want. So I was thinking about how do we avoid being swept by the buzz, and I posed a question there, and it's, what does AI do? And do we need that done in the health sector? So it's about the technology's capability versus the opportunity to utilize that capability in the health sector. The question is, if so, how? And of course, that then looks at how it impacts on the health workforce, how it impacts on the actual health outcomes for the populations that are being served by the technology and the health workforce. Next slide, please. So specifically in Kenya, I think AI is generating a lot of interest, a lot of exploration, and especially around the area of disease detection. I put in brackets some of the organizations we've come across, Vectorgram, that actually has been looking at early detection of breast cancer. And they have developed the models and are now looking at how they can contextualize. And I think that has been mentioned before, the importance of context, especially for AI, because if it's trained in one context, it may not largely map out to another context, although we know the human body is generally the same across the board, but then the factors around health and healthcare and what causes illness vary across. So being able to contextualize technology, AI, for very specific contexts is important. We also have AFIA Record that's looking at leveraging AI for tracking and managing personal health records. And of course, we've had quite a few attempts at chatbots using AI, like SophiBot, that are being used to try and provide both triage support, but also help patients quickly identify what the problem is. But of course, AI's challenges include access to adequate contextual content to limit or even avoid bias. I think a lot has been shared. AI is trained, AI learns from existing content and information that's been created by human beings, and then begins to map out, look at trends, and even become a bit more predictive. So the question is there adequate contextual content to apply AI in any scenario? If the AI is being trained on largely theory versus what is on the ground, then it may end up reproducing theory, and unless there's adequate information, adequate examples of how practice and real life is, then it could largely remain theoretical or take much longer to be more practical in terms of the support it gives. Next slide, please. So looking at AI for health, I think one of the areas, again, it's been mentioned, is AI's ability to synthesize large volumes of data. That remains one of the biggest advantages of the technology, whether it's epidemiological data, patterns, get to the point where it can either predict or help simulate scenarios that can really help the health sector be more responsive to its immediate environment. But noting also that patient care happens during the consultation. So that's a human touch that has already been mentioned. And there's always anxiety, is AI replacing the human, the person you visit and talk to and tell what you're going through, and they listen and they help diagnose and help provide treatment and care and follow-up. Can technology really take that human role? If not, then it's about how the technology can support the human that's actually providing the healthcare. So there I note that any support in synthesizing data in real time or in the context is where AI can play a key role. I was thinking about it, if an expert, a doctor, is trained and practices for, say, 10 years, it's highly likely that their knowledge and expertise would revolve around interacting with an average of, I think, 24,000 patients. I was estimating so many patients a day, so many days in a month, and so many months in a year, and across 10 years. But what if AI could help take that one doctor's experience, another doctor's experience, and sort of pool all these experience together and help generate more knowledge and more insights than one expert can actually experience in a lifetime? That would, to me, would be more supportive than replacing the doctor. So for, like I said, for less than 10 minutes, you see a patient. There's only so much information you can gather from one particular patient. Sometimes in healthcare, it takes longer to diagnose if the symptoms are not clear or if they look similar to another illness. And you'll always hear about sometimes misdiagnosis. Can AI begin to help supporting the health workforce in actually being able to execute their mandate effectively by leveraging more data than a human being can process, by being able to simulate more scenarios than the human mind can, and presenting this information back to experts who can then learn and grow through the support of artificial intelligence. Next slide, please. AI also could play a very key role in health policy and guidelines. Evidence-based policies and guidelines are critical in their context for ensuring that the health sector is able to function properly. So if it's possible to leverage and harness artificial intelligence to take data in a very specific context and continue to synthesize and provide insights that are very contextual, then that would allow our health policies and guidelines to really be fit for our context. And it varies. Context will always vary. What you do in Asia versus Africa or North America would vary based on context. And AI can be leveraged to actually try and process as much data as possible to provide insights for that specific context. I've talked about extensive contextualization for policy regulation, looking at culture, ethnography, and other factors of health beyond the health services. So is it finance? Is it climate? Being able to synthesize all this to provide insights that can be used for policy. The health innovators also and community must also increasingly safeguard against corrupt information. You've heard already that AI is trained based on existing data and information. And there's always a risk that if someone was really nefarious and intentional, they could populate sort of these sources of information with inaccurate information that then gets built into the artificial intelligence and the insights that it produces. So corrupt information or context bias that we mentioned a bit earlier, those are things that we must continually safeguard against, or at least recognize, and where it's context, then recognize that this AI has been specifically trained for this particular context, and ensuring that that bias does not disadvantage anyone else within that context. I think there have been many examples of facial recognition where it's had biases and so on and so forth. So it's not a perfect technology. Human beings are not perfect either, but there's an opportunity to continuously think about the ethical considerations to ensure that AI is actually an assistive technology and assisting the health sector to actually be able to deliver significant health impact for the populations. Next slide, please. So I think this will be my last slide. And it's just a reminder that technology is a means and not an end. Like I said, the buzz always makes it sound like if you don't have AI, you're doing nothing. But the question is, what is AI doing for you? What value is it adding for your processes? What value is it adding for your profession? What value is it adding for your patient, for the customer, and for the whole system at large? With all new technologies, it's important to design and use them as an enabler and an accelerator for impact, and not as the impact itself. So AI should accelerate the outcomes for positive health outcomes for our population, and not just be AI for itself. I'll give an example for AI for nutrition. If you have a term like that, the only assumption I would make is that AI is providing insights for nutrition programming, but does not feed the malnourished child. AI could be used to detect weather, forecast weather, ensure that our population is able to plant and have a significant harvest, which then leads to actual nutrition for children. So AI for nutrition as a term, if that was to be used, is supposed to be assisting and enabling, but we know that nutrition happens when the child consumes a healthy meal. So if AI contributes towards availability, accessibility, and predictability of nutritious foods for our population, then it can support our nutrition, but not by itself. AI for cancer detection, I think the example has already been given, could help in early detection, testing, but always remember that the care for the patient is still a human-driven process. So for me, technology is a means and not an end, and AI has the potential to assist the current processes so that those in the healthcare sector are able to offer effective care for our patients. Thank you very much.
Thank you, Willie. There's something that I read, Willie, in your bio, which actually really goes really well with what you talked about. And it's one of your favorite self-quotes. If you can clearly and accurately define a problem, the solution to the problem lies in the description. And I think that's the key here. You know, what are the things that we know AI can actually logically help us with right now? And Kay, you pointed to this when you talked about what are the impact of classical AI? Where can we use it? Where do we know it works? Where does it have a certain level of evidence? And I think that really is important, because that then drives forward what we do in the future, you know, what we focus our efforts on. And make sure that when we're thinking about things like generative AI, we really are considering the impact of research and evidence synthesis before we actually go ahead and start to crack on and use it, particularly in healthcare or people-facing applications of it. Looking at the chat, there was something that we picked up on that we thought would really give us a view on the question that you asked, Cris, in terms of just because we can do something, should we do it? And it was a response which highlighted that the answer was yes, we should. We have the opportunity to explore and develop AI from inside the NHS within cancer services. We have seen the ability of it being used in places like in diagnosis of breast cancer, for example, but also in the identification of things like lung cancer. And the key thing to consider is we need to understand what the risks are, have clear issue logs, and have clear governance, both from within the NHS, but also in terms of the people that we work with that develop these technologies. And that's how we can truly support the workforce to be able to do that. So I'd like to thank that comment that came through in the chat, because that is really helpful. And what I've seen, actually just seeing from the chat and just seeing from those of you that have engaged so far, is we really do have an audience here which has a mix of people from healthcare workforce backgrounds, people who are educators in the room, and as well as people that are in kind of more operational roles, and people from social care and the wider council. I've seen someone from a council in the chat as well. So really appreciate that wide audience that we have here today. And I wanted to bring us back to that core question then. Just because we can do something, should we do it? Because what we've heard so far is lots of nuances in terms of regulation, in terms of ethics, in terms of the issues around evidence and integration, and what we see before in terms of bias. But at a very high level, I think the critical question for our panelists is, what's your conclusion? Should we do it? And why do you say that? So I'm going to go first with that question to put you on the spot, Cris, because you haven't spoken to us for a while. So Cris, what's your view on the question that you asked yourself?
So, I mean, broadly speaking, actually, my answer is quite simple. It's either, I vacillate between no and it depends. So I think we're talking about investment of time, investment of resources, investment of brain power, investment of so many things. So it's not just a case of cooking up a tool or an intervention or whatever and implementing it. If we're talking on a financial basis, and I'm talking from the context of the European region, I think that you need to figure out what it is exactly the work is supposed to achieve, and whether or not actually it's going to generate any significant improvement in comparison to potential investment of the same resources and costs elsewhere. Now, that's not an easy thing to do, but there are processes in which you need to think about the design and the implementation and the adoption of technologies and artificial intelligence, etc. And you need to take in a broad gambit of other things that are going on. So it's a systematic policy governance part of the equation, and you need to get that right. It doesn't mean that the AI or the adoption of the technology wasn't appropriate if you don't do it. It just means that potentially at that degree, that point in time, with the degree of resources available and the other requirements on any particular health system or service, then it might not have been the most appropriate spend of money. And I go back to the thing that sort of Kay and Natalie were nodding on earlier when I talked about the amount of money organizations like the NHS and others have spent on IT that's gone wrong. It's that sort of thinking we need to do. What happens if this goes wrong? What is it that we've lost? And more importantly, or equally importantly, should I say, if I do this now, what is it I can't do? And it's a bit like going into a car showroom, to take it its most simple basis. I may be able to afford that car, but doesn't mean to say I necessarily need to buy it because there is another option.
So I'm gonna jump in just because Tim unmuted the mic and I'm sitting next to him. I mostly disagree with you, Cris, but agree with you a little bit. And so I think we need to do it because it's got a tremendous amount of value, but it's got to be done very intentionally and with an appropriate amount of governance. And so, and not appropriate, only appropriate amount, but the appropriate kind. And the governance, especially of this newer technology, is very different, or a big additive on top of the traditional, what I call old school AI from 2022. And so I think it's important to be intentional. It's important to make sure it's adding value. I think you and I agree on that. But we need to move forward today. We just have to. Yeah, I'll leave it at that.
I will let Cris come back very quickly on that, and I'm going to go to Kay.
Perhaps let Kay go first, because she may say something I was going to say, and I don't want to steal her words again.
Yeah, absolutely. Go on then. Over to you, Kay.
Yeah, I actually think I probably fall between Cris and Seth. I think that what we have to do is be very intentional about what it is that we decide to do with AI. And, look and say, well, where could it be beneficial? Where is it succeeding at the moment? So in reading X-rays, for example, we know it's very good. And because the NHS is cash strapped, I think most medical environments around the world are fairly cash strapped. We have to be very intentional about it. So can we use it for prevention, which will then mean that we don't have to spend the money on cure? And so first of all, I would say, yes, let's explore it in prevention. And then secondly, I would say, let's explore it in worker support. So just basic things like backroom writing notes, those sort of things. And thirdly, I would say only if you have good governance, which is Seth's point. And fourthly, I just want to remind people, which is why I'm sitting between the two, what Seth said. This is very hard. People with companies with large amounts of money are not necessarily succeeding in deploying AI. And so we should be really cognizant that if that's happening in industries where there's lots of money to be spent, we should be very careful about being very targeted in how it's spent here.
When I think of the use of AI in healthcare, and I'm saying this as a practicing GP, I see, I have patients that are waiting often a month for a report to come back on an X-ray that they've had. And I have 10 minutes to document for my patients, as well as see them. And, that's a lot to do in 10 minutes to provide good interaction, as well as document that interaction to protect myself from a medical legal point of view, but also to have an accurate record of the conversation and the consultation that we had. So there are, I think, areas that we know it could have an immediate impact, but we need to do it safely and accurately.
And radiologists, there's a 30% false negative rate on radiograms. And so that's a whole nother problem too.
Yeah. So when you try and do that autonomously, that creates a significant challenge. So actually, maybe that things are not need to be autonomous. We need to have the humans in the loop. Going back to Cris very quickly again for your rebuttal.
So I don't actually think there's an awful lot of blue water between us, Seth. Okay. I'm not talking about AI in the global perspective. I'm talking about, I absolutely agree. It is a force for good. Potentially for the future, and we should be looking to invest in it and to find ways and means of appropriately using it. I agree wholeheartedly on the governance aspects. I think stewardship and governance of any intervention is key and critical. I'm more thinking about the individual aspects. When we're thinking about individual service packages, individual issues, we have to have a solution for a problem, not a problem to fight that fits the solution. And in a lot of things that do happen sometimes, we think, well, I've got a great thing here. It's going to deliver some really good solutions, etc., etc. Let's roll it out. And I've seen that in a number of cases. So in short, Seth, I do agree with what you say. It's appropriate governance, but I think we're in a fail-safe industry as well. We have to remember that. I think it's appropriate application, and I think that's when it actually delivers real benefits, and even marginal benefits, to use the cycling analogy, are beneficial and can deliver savings further down the road. But I guess the point I come to is I've very often seen investment in new technologies, and AI being a new technology, or relatively new technology, should I say, doesn't necessarily mean investing in it because it's new and whizzier and faster and go faster stripes all down. It necessarily delivers the benefits we think. So we have to be measured. We have to be brave, and we have to find money to do it, but we have to be measured, and we have to be appropriately cautious.
Yeah, I think that's really the critical part. And I'm going to go over to Natalie for your thoughts, but I'm also going to pose to you the next question, which I think is a really interesting question, because it's asked by SK Nayak in the chat, in the question Q&A, and it's about devil's advocate. So I'm sorry, I am asking these questions. It's a very difficult question to answer, but you have worked with workforce and thought about the initiatives to support the workforce with AI. So the question is, how is AI not going to take away jobs from nurses and physicians? So if you have a view of that, that'd be really good. But I'll let you start with some reflections of what we've heard so far.
So perhaps just for the previous question, the perspective I perhaps wanted to bring was that in our case, what we realized was that we couldn't stop it. I mean, the hospital is full of people. We talked about 20,000 actors who hear about AI and who were hearing about AI back in 2018. So back in 2018, we realized a bunch of people were already working on these projects. So you have a bunch of individuals, before there's even an organizational strategy, before people are even talking about AI governance, already talking about how AI is going to perhaps work with them or help them in their everyday life. So it's really important to give them what they need in order to be able to make critical choices and give good judgment and support that through governance, but also through organizational strategies. But you can't control it. It's It's already there. It's coming in. So the more you equip your teams and your people to be able to pose those critical questions and understand what the true impact is of this technology and what the true cost is, you're going to be managing your risks, I would say. Now, concerning, sorry, the second question was, is it going to steal our jobs? No. I think it will create a lot of jobs. I think it will change a lot of jobs, and which is why I keep talking about how important it is to focus on those human skills. We can talk about how robots roam the corridors here at the SHIM in order to be able to transport things. So it's great. People aren't getting injured or hurt transporting laundry from one section of the hospital to the next, and we're able to put those people, patient front as much as possible. And I think by focusing on the patients, focusing on people's creative skills and getting them ready to be able to work and live and thrive in an environment that's going to be constantly changing faster than we can necessarily adapt to it, is what's key. But I do think that nurses and doctors, patients expect them to be there. Patients need them to be there, and the human contact will remain. It's universal, and I do feel like we all need it, and we will always need it. And absolutely, that story about the iPad, wow. You need the human at the end of the day.
Yeah, I think so. I'm going to be a naughty chair of this event and actually provide a bit of a view on this. And I completely agree. I think ultimately, and it's something that Seth, you said to me in the past, I think if humans take ownership of this and are clearly overseeing its implementation, then we will use it in the right way if we do that with the right purpose and the right morals and the right values. And I believe in healthcare, we do have those right morals and values and what we want to do to help people and preserve people's lives. And Kay, you talked about preventative healthcare, and my reflection is the work that I do as a practitioner is most of the time not preventative, but actually quite reactive. And there's a kind of this notion in the United States about sick care rather than healthcare. And I do believe that actually, if we're smart about it, we could use this technology to help us move that dial forward into the world of preventive healthcare and improving disease. And therefore, a critical part of that is the workforce for the future. And there was a question in the chat, and I'll come back to Cris and Seth, you might have some reflections in the room. But very quickly, there's a question in the chat around what do we tell our children? And that was asked by Ian O'Neill. And I think that's really interesting, because what about the next generation of healthcare workforce? What do we need to be putting in place for them? And I was going to go over to Willie, because you talked about purpose a lot. You're very kind of intentional in the way you describe the use of AI and your role in kind of capacity building and health system strengthening. What do you think in terms of how we best prepare the next generation of people that are going to be working in healthcare, and how we make sure they are prepared for this technology?
Well, that's an interesting question, because I think the next generation will be upset at us for not trying it out. They think, why do I still have to do all this? Why do I have to do this manually? Why do I have to? They should have. Can someone create something that does this for me? Because there's a lot of apps and technology that the young new generation of are using to help and aid and support and assist in the things that they do. So I think if you're looking at the next generation, I think for that reason alone, it's important that we explore AI to its fullest. In our current context, perhaps as an assistive technology that does the things that yourself as a doctor may not have time to do. Can AI help you do that? If it's reading up something, if it's synthesizing information, if it's looking at charts and looking at patient data and trying to bring out insights, can it do that for you and then help you? So by the time the next patient walks into your clinic, you have a bit of synthesized information about their health that allows you to query more intelligent questions to them, because you've already identified quite a bit. So I believe it should be an assistive technology for now, but it's worth exploring so that we can really know what it's capable of. But for the future generations, I think we kind of owe it to them a little to explore it so that it can be of more value for them than it might be for our current generation. When you think about all the research that went into health way back, that led to discoveries, that led to mapping of the human body, that now becomes part of your training as a medic. You're not having to research that yourself. Someone else did it and has built on knowledge. So I think for AI, I was going to say, I didn't want to sound like the guy who said you're not going to need more than 1 megabyte of storage way back. Because back then it was mind-blowing. 1 megabyte. Now we have terabytes and petabytes. So I don't want to sound like, nah, we don't need it. But I think this generation should continue with the research and establishing how does AI support health. So by the future, there'll be products and services that are well-tested, well-regulated, well understood, that actually aid in provision of healthcare. I think the prevention approach is also one. When we talk about prevention and then preparedness and then the actual response. So AI could actually go a long way in prevention. AI can process Kenya's context, our disease profile, our rain profile, a lot of data that a doctor may not be able to process. It should do that for prevention. For preparedness, it can do forecasts, it can do scenario planning. I think there's a lot of that now with Ebola and COVID, where people think, what if? What are the what ifs, so that we are better prepared? So AI can support us with that. And then, of course, in the event of impact of any disease, quickly establishing patterns and perhaps identifying. I think that was a great story given, identifying what the problem is so that we can get to care faster. So we owe the next generation a bit of effort into research. But for now, I think it's an assistive technology.
Thank you, Willie.
So, I mean, I think really, really good points. I think there's a few sides to this. So one is, and Qantm and I were talking about this earlier, in the UK, you have an availability issue with healthcare. In the US, you have an accessibility issue in healthcare, and pretty much everywhere else in the world falls somewhere between there, outside the Nordics. And when you look at availability, generative AI has the opportunity to really slim down the amount of work that physicians need to do, that nurses need to do, that medical practitioners in general need to do, that makes it more available. In terms of accessibility, AI has the potential to reduce costs, both of actually doing the activities, but also of the risks. And so, for instance, a personal story, not as, personal story, where I had a knee replacement. And my doctor at Hospital for Special Surgery in New York, again, I have access because I have money. He did my knee surgery, and he actually did a CT scan of my knee. He had a custom part made based on that CT scan, and he did the surgery 30 times before he opened me up. That greatly reduces his risk. That greatly reduces my risk, which eventually will lower the cost. And so that's a huge opportunity from an availability perspective. Even in the UK, it increases accessibility, reducing risk because you can hire more staff. Then you get into things like we talked about earlier, where you have fewer false negatives. I'd rather have, in most cases, a false positive than a false negative. 30% false negative rate in radiology is concerning. The concordance rate among radiologists is even lower. And so that's, even just getting multiple people to do it doesn't really fix the problem because you don't have concordance. And so how can you use AI to help with that? So you still would have an AI read it, identify what it thinks is, and then you have a human review it, because you absolutely, anytime AI directly impacts health, wealth, or livelihood of a human being, a human needs to be involved. The EU AI Act aligns with that. So that's an important piece. In terms of our children, we need to train them to use this technology appropriately. So I teach a class at one of the city universities in New York. I'm going to start at NYU on AI safety, but they must use generative AI in part of the class. And so think about it, a Socratic method of teaching, except, I pose questions, they use generative AI to help them answer the questions. They have to check their work, they have to synthesize it, but teaching people to actually use AI appropriately, especially generative AI, is really important.
Yeah, I think so. My personal view on this is that, and it's actually what Ian says in the chat, is to do this properly, we need to bring everyone along on this journey. And when you talk about the non-clinical workforce, the clinical workforce, what can we do to really make people understand and demystify what potential applications are? But put that in context. What is the possibilities? I know we're coming to the end of time shortly, so I do want to hear some final reflections from the panel. And I want to give you kind of 30 seconds. I can see Kay and Cris have their hands up. I want to go to Kay first because I know you need to run away definitively at 1. So first to Kay, then to Cris, Willie and Natalie, final reflections, and then we'll close up.
Okay, just in answer to the what should we teach our children, I do think that we need to teach them that both. We need to help them understand the technology, not so they can be AI scientists. We don't need so many of them at the moment anymore with generative AI, but they need to understand, because otherwise they can't participate in the debate about what they want of AI and where they want it in their lives. And then on the other side, I think that we need to help them hang on to their humanity, understand what makes us human, and then we can have robust debates about where we use this technology and where we don't actually want to use it. And I think that that's urgent now. There's been a lot of emphasis on STEM education, but really we need to add those humanities back, because critical thinking at this stage of our development of AI is vital. Sorry, that was more than 30 seconds. Thank you.
No, but wonderful reflection, particularly around the humanities aspect of this. Cris?
Okay, I couldn't agree more. Critical thinking is one of the fundamental parts of education, that if we lose it in any country, we lose part of our ability to do business. And we, more importantly, we lose part of our soul. Sorry, a little bit perhaps esoteric there. Willie, I can remember 16K, so that dates me a little bit more than that. So there you go. I'm going to just go back on 2 things around, will we be out of work? No, we won't. The demand for healthcare is growing, and it grows inexorably. You know, people want more and more services. Waiting lists grow in various parts of the world, greater than the workforce. So we won't be putting people out of jobs. We will be finding better uses for people in those jobs and delivering improved healthcare on paper, if we get it right. What we need to do for the future is we need to use technologies, and it's not just AI, it's what follows AI, son and daughter of AI, etc., etc. We need to use those coming forward. We need to educate ourselves, and we need to understand what the implications that they have for saving time in process, improving time and quality outcomes for patients. We have a duty in healthcare services to stop populations becoming patients. So maybe we move AI and technologies down the pipeline into looking, as has been said earlier, about more preventative work, more analysing how societies actually tick and actually work, and where the health points of intervention need to be, so that we can stop people becoming ill earlier. And that last point that Kay made, absolutely, I agree with it 100%. We need to be bringing our young people into the discussions. We need to have them part of the arguments and the consideration. And we need to make sure that we educate our people to think about the process that they're doing, not just how to develop that process. And
thank you, Cris, and I completely agree with you. And we're moving on to talking about that education aspect. Final reflections from Natalie, and then Willie, please.
So you have to remember that in healthcare, people are extremely busy and reactive. Okay, so if you're really wanting to work with them, train them, get them to develop skills, you need to really aim for what I refer to as 4P teaching and training. So we often talk about 4P in medicine, so predictive, preventive, participative, and I'm missing one, personalized. Well, the same thing applies to teaching and learning. So there's no one size fits all. You need to do just in time, just enough, and just for me curriculum if you really want them to embrace it and learn about AI and then work on it.
Yep. I think I'll just say human-centered. What's it solving for human beings? What's it solving for the patient? What is it solving for the practitioner? What's it solving for the researcher? What's it solving for the policymaker? If it has a purpose, if it has something it's actually solving, let's go for it, because the assumption is that if we solve the problem, whatever the problem is, it all links to better health outcomes for the populations. So the doctor wants to give better diagnosis, wants a better medical history. Doctor wants a better sort of context of the disease. If it solves that, excellent. If the policymaker wants to understand the impact, the potential, both current and future impact, and the AI can do that, let's go for it because it can help make better policies. At the end of the day, it's about the human being, good health outcomes, which then translates to a good health system. Thank you.
Thank you, Willie. And a final sentence, and okay, I know you have to go, so please do, if any panelists need to leave, please do go. Seth, a final sentence from you in the room.
Yeah, so just real quick. So Ian brought up a point about back office. Back office is absolutely the place to start. You don't have regulatory issue. Outside the UK, it's treated as a medical device if it's not back office. And I think in terms of, where we're going, I think all the other panelists hit it right on the head. We need to make sure that we're, doing deliberate work for the patients. And ultimately, even when we help the physicians, it's the patients. And part of that is there's something like 1,200 new articles published on PubMed every day. Physicians need a better way to understand that so they can provide the best treatment.
Yeah, I mean, medical knowledge is exponentially rising. Actually, the latest figures show up to potentially 73 days, but maybe even down to 60 days. So how do you keep up with that level of information? It's been a fascinating discussion. We've touched upon governance. We've touched upon whether we should use AI at all. We've touched upon how, if we are to use it, how we do it safely and what some of the use cases might be. We've touched upon how we bring the workforce as part with us as part of that journey, as well as how we prepare the workforce for the future to use this technology. The key thing here is we can't solve this in a couple of hours. It needs global collaboration. It needs global discussions. It needs discussions across people who work in different industries with different backgrounds. And I think we've seen that in the conversation today. So it's been really great to have a wonderful panel. So I'd like to thank Natalie, I'd like to thank Cris, Willie, Kay, and Seth for joining us and providing you with your views, particularly me as a clinician. I really value hearing from all of you and your experts. Any expertise. I'd also like to thank Ian O'Neill, Richard Price, Mutsa Gopara, and for the work in the background, who are as part of the NHS England team. And I'd also like to thank Winnie from Nomad IT, who's been our technical support for the day. And most of all, I'd like to thank those that have joined us today, because I appreciate you giving us your time. The majority of you, that have stayed throughout the whole thing, I really do value that. But I know some would have had to go earlier. And what we are doing is we have recorded this, and we will find a way to share it meaningfully. We also want to continue the discussion and build a community of practice around this, so we can do what we've discussed in the seminar today. So as you can see on the slide, there's a LinkedIn link which you are welcome to join, and please do, let's keep the conversation going and think about how we can work together on this in the future. Thank you so much to everyone. It's been a riveting discussion, and I'm really looking forward to the conversation as we move it forward in the future. Bye, and have